There is a story we tell ourselves about the past. It is a comforting fiction, painted in the soft hues of romance and chivalry, where the sharp edges of reality have been worn smooth by the gentle erosion of time. We imagine an age of simpler truths, of clearer lines between dark and light, a world less complicated than our own. We see the towering cathedrals and hear the faint echo of Gregorian chants, and we mistake the grandeur of the shell for the nature of the life within it. This story is a beautiful lie. It is a necessary one, perhaps, for it allows us to look back without flinching, to claim a heritage without acknowledging the weight of its horrors. The truth, however, is a far more brutal artifact. It does not reside in the epic poems or the illuminated manuscripts of kings. It lives in the bone pits, in the faint scratches on a skull, in the silent, screaming testimony of the forgotten dead. The truth is that for 1,000 years, the human body was a foreign country, a haunted landscape of unknowable terrors, and the mapmakers were blind. To be sick was to be cursed. To be injured was to be damned. And to fall under the knife of a medieval surgeon was to enter a realm of such profound agony that it defies the modern imagination. You think you know what pain is. You believe you understand suffering. You do not. Put your phone face down. Turn the volume to a whisper. We are not going to visit the courts of kings or the cloisters of saints. We are going to a place of blood and iron, of desperation and prayer. We are going to the edge of life, where the only thing separating a person from the grave was a craftsman with a saw, a prayer on his lips, and a profound, terrifying ignorance of the delicate machinery he was about to tear apart. Let's go in. The great forgetting did not happen overnight. It was not a thunderclap of cataclysmic loss, but a slow, seeping tide of decay, the way a fresco flakes and fades in a damp, abandoned church. When the intricate scaffolding of the Roman Empire finally groaned and collapsed under its own immense weight, it took with it more than legions and aqueducts. It took a world of accumulated knowledge, a library of thought painstakingly assembled over centuries, and scattered its pages to the wind. The medicine of Galen and Celsus, with its complex understanding of anatomy derived from the Alexandrian dissectors, its sophisticated surgical instruments of bronze and steel, its emphasis on hygiene and a holistic approach to patient care, all of it fractured. The knowledge did not vanish entirely, but it became a ghost, a half-remembered dream. The arterial clamps, the delicate forceps, the bone drills and scalpels were buried in the earth, their purpose forgotten, their fine craftsmanship a riddle to the generations that followed. The texts themselves, copied onto fragile papyrus, were burned in the sacking of cities or simply crumbled into dust in untended archives. What survived was fragmentary, incomplete, and often misunderstood, like trying to reconstruct a palace from a single, broken shard of mosaic tile. The world that rose from the ashes of Rome was a smaller, darker, more fearful place. The grand, interconnected web of Roman roads, which had once been conduits for trade and ideas, became dangerous pathways stalked by bandits and broken by neglect. Cities shrank into walled fortresses, and life folded inward, becoming local, parochial, and steeped in superstition. In this new world, the intricate dance of sinew and bone, the delicate chemistry of the blood, was no longer a subject for rational inquiry. It became the province of God. Sickness was not a failure of the body's mechanics, it was a failure of the soul. An infected wound was not the result of invisible contagions, but a physical manifestation of sin. A fever was a trial sent by God, a plague was his righteous anger made manifest. The human body ceased to be a machine to be understood and repaired, it became a spiritual battleground, and the physician's role shifted from that of a mechanic to that of an intercessor. The center of learning, what little of it remained, retreated behind the thick stone walls of the monasteries. Here, amidst the silence of the scriptorium and the scent of beeswax and old parchment, monks became the reluctant custodians of a broken tradition. They dutifully copied the surviving works of the ancients, their Latin often poor, their understanding of the complex medical theories even poorer. They preserved the words of Galen, but they filtered his science through the dense gauze of theology. His theory of the four humors, blood, phlegm, yellow bile, and black bile, was particularly appealing, for it resonated with a worldview that sought balance and divine order in all things. The body was a microcosm of the universe, and health was the perfect equilibrium of these four elemental fluids. Illness was an imbalance, a disharmony that must be corrected. This theory, elegant in its symmetry and fatally wrong in its premise, would cast a shadow 1,000 years long, dictating the course of medicine and justifying treatments that were often more lethal than the diseases they sought to cure. Surgery, the direct, physical intervention in the sacred vessel of the body, became an act of profound transgression. It was bloody, manual work, seen as beneath the dignity of the learned, a craft for butchers and laborers, not for men of God. The Church, in its wisdom, decreed ecclesia abhorreta sanguine, the Church abhors the shedding of blood. This was not an outright ban, but a powerful disavowal that pushed the practice to the absolute fringes of society. Monks, the primary keepers of medical knowledge, were forbidden from performing procedures that involved cutting or burning. And so, the knife and the saw were laid down, left to rust alongside the forgotten knowledge of the arteries they were meant to avoid and the organs they were meant to repair. A great wall was erected between medicine and surgery, between the theoretical and the practical. On one side stood the physician, a man of letters and prayer, who would diagnose an illness by examining the color of urine and consulting the alignment of the stars, but who would never, ever touch the afflicted. On the other side, in the shadows, a new and necessary figure was about to be born from this schism, a craftsman who would inherit the bloody, hands-on work that the physicians and monks had so eagerly abandoned. He would not be a man of learning, but a man of the blade. He was the barber. In the medieval city, a chaotic tapestry of timber, wattle, and daub crowded under the watchful eye of a cathedral spire, life and death were intimate neighbors. The streets, narrow and choked with mud and refuse, were the stage for a constant, casual brutality. Here, in this world of precarious existence, the line between professions blurred. The man who shaved a beard was also the man who pulled a tooth. The man who cut hair was the man who lanced a boil. This was the birth of the barber-surgeon, a hybrid practitioner forged in the crucible of necessity, a figure whose iconic striped pole would become a symbol not of grooming, but of blood. The red stripe represented the blood itself, the white, the bandages used to staunch its flow, and the pole, the staff a patient would grip to make their veins bulge for the letting. His theater was not a sterile chamber but a common shop, open to the street, its floorboard stained dark with the accumulated evidence of his trade. The air within was thick with a cloying medley of scents, the cheap soap used for shaving, the sweet, metallic tang of fresh blood, the foul stench of pus from an abscess, and the acrid smoke of the cauterizing iron hissing against flesh. This was not a place of healing in the modern sense, it was a workshop of the body, a place of last resort where pain was the currency of survival. The barber-surgeon was, above all else, a craftsman. He was not a scholar. He was often illiterate, his knowledge passed down not through books but through a brutal apprenticeship. He learned his trade the way a carpenter learns to joint wood or a blacksmith learns to shape iron, by watching, by doing, by trial and by a great deal of error. His hands, calloused and strong, were his primary diagnostic tools. He palpated the swollen belly, probed the festering wound, and set the fractured bone with a visceral, tactile understanding that the university-trained physician, with his abstract humoral charts and astrological calendars, could never possess. His allegiance was not to the elegant theories of Galen but to the grim realities of the human body's capacity for injury. His patients were not wealthy nobles who could afford the gentle, ineffective ministrations of a physician, but common folk, the mason who fell from a scaffold, the soldier with a crossbow bolt in his thigh, the woman with a gangrenous sore on her leg. They came to him not for comfort or for answers, but for a stark and terrible transaction. They would trade a limb for a life, a moment of unimaginable agony for the chance at another sunrise. His tools were an extension of his craft, simple, brutal, and utilitarian. They were laid out on a wooden tray, a terrifying inventory of purpose-built violence. There was the razor, of course, for shaving and for making the first swift incision. There were lancets for bloodletting, fleams for opening veins, and cupping glasses to draw the corrupted humors to the surface. For deeper work, There were scalpels of varying sizes, crude hooks and retractors for pulling back muscle and tissue, and long, slender probes for exploring the depths of a wound. And then there were the instruments of last resort, the tools that spoke of desperation. The amputation saw, with its wide-set teeth designed to cut through bone without binding. The trepan, a cranial drill resembling a carpenter's brace and bit, for boring into the skull. And most fearsome of all, the cauterizing irons. Kept glowing in a brazier of hot coals, these instruments, shaped into flat plates, sharp points, or hollow circles, were the surgeon's answer to the two great enemies he could not conquer, bleeding and infection. The searing of flesh was his only method of hemostasis, a horrific, agonizing, and often ineffective means of sealing a severed vessel. It was also his only concept of sterilization. In a world haunted by invisible poisons, the cleansing power of fire seemed a logical, if brutal, solution. To burn the wound was to purify it, to drive out the malignant humors that caused it to fester. This act, the application of glowing metal to living tissue, was the defining sensory experience of medieval surgery, the smell of cooking meat, the shriek of the patient, the black, carbonized flesh left in its wake. This was the world the barber-surgeon inhabited, a world defined by the limits of his knowledge and the strength of his nerve. He was a figure caught between two worlds, scorned by the learned physicians for his lack of formal education, yet revered and feared by the populace who depended on his crude but essential skills. He was the man who walked in blood, who traded in pain, and who stood on the flimsy precipice between a brutal life and an agonizing death, holding a blade. The greatest enemy of the medieval surgeon was not the swiftness of death or the agony of the patient, but a more fundamental and pervasive foe, the darkness in his own mind. He worked upon the human body as a man trying to repair a complex clockwork mechanism in a pitch-black room, guided only by touch and a set of faulty, inherited instructions. The interior of the body was terra incognita, a mysterious and sacred realm that was not to be trespassed upon. The profound prohibition against human dissection, enforced by both religious doctrine and deeply ingrained social taboo, was the single greatest barrier to medical progress for 1,000 years. Without the ability to open the dead, to see the architecture of life firsthand, the surgeon was functionally blind. His understanding of anatomy was a patchwork of inherited falsehoods, animal analogies, and pure, imaginative guesswork. The primary source of anatomical knowledge came from the dissection of animals, most commonly the pig, whose internal organs were thought to bear a close resemblance to those of a human. This reliance on porcine anatomy led to centuries of compounded errors. Surgeons believed the human liver had 5 lobes, like a pig's, not 2. They thought the human uterus was bicornuate, with 2 horns, like that of a sow, the rete mirabile, a complex network of blood vessels at the base of a sheep's brain, was assumed to exist in humans as well, and was assigned the critical function of refining vital spirits. These were not minor inaccuracies, they were fundamental misunderstandings of the body's basic blueprint. To cut into a person with such a map was to navigate a treacherous sea using a chart of a different ocean entirely. The anatomical charts and illustrations that circulated in the medieval period were not scientific documents but works of art, more symbolic than representational. They depicted a body that was a vessel for the soul, a stage for the interplay of humors and astrological influences. Figures were often shown with their abdominal cavities open, displaying a neat, symmetrical, and entirely fanciful arrangement of organs. The intestines were a perfect spiral, the stomach a simple flask, the arteries and veins a tidy, color-coded system of red and blue channels originating from the multi-lobed liver and the heart. These were diagrams of a theological concept, not a biological reality. The surgeon who looked to these for guidance was being led astray, his ignorance reinforced by the very texts that were supposed to enlighten him. This profound anatomical darkness had devastating practical consequences. A surgeon attempting to remove a bladder stone, a procedure known as a lithotomy, would cut into the perineum, guided by a vague sense of where the bladder ought to be, and grope blindly for the stone with forceps. The risk of perforating the bowel, causing a fatal infection, or severing a major artery was immense. When treating a deep wound from a sword or an arrow, the surgeon had no clear idea of the structures that lay beneath the surface. He might mistake a tendon for an artery, or a nerve for a ligament. The act of probing a wound, intended to remove foreign objects like dirt or cloth fragments, could do more damage than the initial injury, pushing the contaminants deeper or tearing delicate tissues. Even the most common of major operations, the amputation, was a terrifying gamble. The surgeon knew he had to cut through skin, muscle, and bone, but his knowledge of the vasculature was rudimentary at best. He did not understand the difference between an artery and a vein in a functional sense, nor did he possess a reliable method for ligating a major vessel. The tourniquet was a crude and often ineffective device, and the primary method of controlling hemorrhage was the horrifying application of the cauterizing iron or boiling oil to the raw stump of the limb. This was not a precise technique, it was an act of brutal, indiscriminate destruction, charring nerve, muscle, and vessel alike in a desperate attempt to seal the wound against a fatal bleed. The very concept of the body as an integrated system was absent. The brain was a cooling organ for the heart. The nerves were hollow tubes that transported animal spirits. The heart was the seat of emotion, and the liver was the factory of the blood. Without a true understanding of physiology, of how these parts work together, medicine was doomed to treat symptoms rather than causes. The surgeon saw a swollen leg not as a sign of a systemic circulatory problem, but as an isolated collection of bad humors that needed to be drained. He saw a fever not as the body's response to infection, but as an excess of heat that needed to be counteracted by bleeding the patient into a state of weakness. He operated in a void, a man armed with sharp tools and the best of intentions, but utterly lost in the very territory he sought to command. Every cut was a leap of faith, every procedure a prayer against the unknown. There was a demon that inhabited the surgical theater of the Middle Ages, an entity more feared than the surgeon's knife, more certain than death itself. It was pain. Not the fleeting, manageable pain of the modern world, cushioned by pharmacology and dulled by anesthetics, but a primordial, all-consuming force, a tidal wave of pure agony that threatened to shatter the mind and stop the heart. In an age before the discovery of ether or chloroform, before the delicate science of nerve blocks and opiates, the experience of surgery was a descent into a waking hell. There was no escape. There was no relief. There was only endurance. The prelude to the operation was a ritual of psychological terror. The patient, often already weakened by illness or injury, was fully conscious, their senses sharpened by fear. They saw the array of instruments laid out, the gleaming saws, the cruel-looking hooks, the irons glowing in the brazier. They heard the surgeon's low, murmuring consultation, the terse instructions to his assistants. They smelled the smoke, the blood from the previous patient, the sharp, metallic scent of fear itself. The operating chamber was not a place of quiet contemplation but of raw, physical struggle. The concept of a willing, cooperative patient was a luxury that did not exist. The body's instinctual reaction to the violation of the knife is to fight, to flee, to recoil. To counteract this, the patient was not gently prepared but physically overpowered. Strong assistants, often blacksmiths or other laborers paid for their muscle, would seize the patient, pinioning their arms and legs. Ropes and thick leather straps were used to bind them to the operating table or chair, lashing them down like a sacrifice to an unforgiving God. This act of restraint was the first wave of the assault, a violent suppression of the will that preceded the violation of the flesh. And then, the surgeon would begin. The first touch of the cold steel blade was a shock, a sharp, electric signal of the horror to come. As the knife sliced through skin and muscle, pain would erupt, not as a sensation, but as the patient's entire reality. It was a white-hot, blinding light that erased all other thought, all other feeling. The body would arch against its restraints, the muscles knotting into iron bands. A scream would tear from the throat, not a sound of communication but a raw, animal noise, the body's primal protest against its own deconstruction. The surgeon had to work through this chaos. He had to be immune to the shrieks, deaf to the pleas for mercy. His focus had to be absolute, his hands steady even as the living table beneath him convulsed in agony. This necessity bred a particular kind of surgeon, one who was not only skilled but also swift. Speed was the only form of mercy he could offer. An amputation that took minutes instead of seconds was not a more careful operation, it was a prolonged torture that could send the patient into the deadly embrace of surgical shock. The great surgeons of the age were renowned not for their delicacy but for their breathtaking velocity. They were masters of a terrifying choreography, a blur of motion as they cut, sawed, and cauterized. A leg could be removed at the thigh in under a minute, a testament not only to skill but to a necessary hardening of the heart against the suffering they inflicted. The sensory experience for the patient was an overload of horror. They felt the grating vibration as the saw bit into bone, a deep, sickening sensation that traveled up the entire length of their skeleton. They felt the surgeon's fingers probing and pulling within the wound, a grotesque intimacy of violation. They smelled their own flesh burning as the cautery was applied, a foul, unforgettable stench that would haunt them for the rest of their short lives. They heard the rhythmic, wet rasp of the saw, the sharp crack as the bone finally gave way, the sizzle and pop of the hot iron quenching in their own blood. For many, the ordeal was simply too much. The human heart can only withstand so much trauma. Patients would die on the table, not from blood loss, but from the sheer, overwhelming shock to the nervous system. Others would lose consciousness, a small mercy granted by a mind that could no longer process the onslaught. And for those who survived the procedure itself, the memory of the pain would be an indelible scar, a psychological wound that would never fully heal, a constant, whispering reminder of the price of their survival. This tyranny of pain shaped every aspect of medieval surgery. It limited the scope of what could even be attempted. Procedures that required time, delicacy, and a still patient, such as intricate abdominal or thoracic surgery, were simply impossible. The surgeon was a warrior, not a watchmaker. He could perform bold, destructive acts like amputation or trepanation, but the fine, restorative work of modern surgery was beyond his grasp. He was forever locked in a desperate, high-speed battle against the conscious, screaming agony of the person he was trying to save. If pain was the loud, shrieking demon of the operating theater, there was another, quieter entity that lurked in its shadow. It was a patient and insidious killer, a ghost that followed every cut of the surgeon's knife. It was the specter of infection. In the medieval world, the enemy was not only unknown, it was entirely unconceived. The very notion of microscopic organisms, of bacteria and viruses, was a fantasy as outlandish as a voyage to the moon. The air was just air, the dirt was just dirt, and the surgeon's hands were just hands. The science of germ theory lay centuries in the future, a distant, unimaginable shore. Without this knowledge, the concept of hygiene as we understand it was completely absent. The surgeon operated in a state of what can only be described as spectacular filth. The operating room, whether it was a room in a primitive hospital or the corner of a barber's shop, was not a sanctuary of cleanliness. It was a place where the residues of daily life and death accumulated unchecked. The floors were often bare earth or stone, covered in straw that was soaked with blood, pus, and other bodily fluids. The operating table itself was a simple wooden plank, wiped down with a dirty rag, if at all, between patients. It bore the dark, greasy stains of countless previous procedures, a silent testament to the suffering it had witnessed. The surgeon himself was a primary vector of contamination. He operated in his ordinary street clothes, a heavy woolen or leather apron worn over top to protect them from the worst of the gore. This apron was a badge of honor, its layers of dried blood and grime a sign of his experience. He did not wash his hands before a procedure, there was no perceived reason to. He might wipe them on his apron or a nearby cloth, but the idea of scrubbing to remove an invisible threat was non-existent. His fingernails would be caked with the dirt of the street and the organic matter of his previous work. He approached the open, vulnerable wound of his patient with hands that were, by modern standards, biologically toxic. His instruments were no cleaner. After an operation, a saw or a knife would be wiped clean of blood and tissue and put away, ready for the next patient. There was no boiling, no sterilization, no antiseptic wash. The same knife that had just cut through a gangrenous leg might be used, moments later, to lance a boil or stitch a wound on another person, directly transferring the deadly bacteria from one to the next. The sponges used to mop up blood were used again and again, rinsed in a communal bucket of cold, murky water and left to dry, becoming stiff, petri dishes of microbial life. Even the materials used to dress the wound were sources of infection. Sutures were made of common silk or hemp, unsterilized. Bandages were often made from old rags, linen collected from households, unwashed and teeming with bacteria. Instead of protecting the wound, these dressings served to introduce new contaminants and seal them inside the warm, moist environment of the damaged tissue, creating a perfect incubator for sepsis. The tragic irony is that medieval surgeons did not see infection as a complication to be avoided, but as an integral, and even desirable, part of the healing process. They observed that deep, healthy wounds would inevitably produce a thick, creamy, yellow-white pus. From this observation arose the doctrine of laudable pus, pus bonum et laudabile. The formation of this pus was believed to be the body's natural method of expelling the malignant humors that had caused the illness in the first place. A wound that did not suppurate was considered a grave sign, an indication that the body was too weak to mount a proper healing response. Surgeons would therefore actively try to induce the formation of pus. They would pack wounds with irritating substances, turpentine, egg yolks, even animal dung, to encourage what they saw as a healthy, cleansing discharge. They deliberately transformed a clean wound into an infected one, believing they were aiding nature. The consequences of this universal ignorance were catastrophic. The vast majority of patients who survived the initial shock and blood loss of a surgical procedure would succumb in the days and weeks that followed to the slow, agonizing creep of infection. The wound would become hot, swollen, and red. A throbbing pain would set in. The patient would develop a raging fever, chills, and delirium as the bacteria entered the bloodstream, a condition known as septicemia. Gangrene would set in, the tissue turning black and putrid, the foul smell of decay filling the room. For the patient, this was a second, crueler ordeal. Having endured the raw agony of the knife, they were now subjected to a slow, systemic poisoning. They died not from their original injury, but from the surgeon's cure. This silent, invisible killer rendered medieval surgery a grim lottery. A surgeon could perform a technically perfect amputation, a swift and masterful display of his craft, only to watch his patient wither and die from an enemy he could not see and did not know existed. The mortality rates for even minor procedures were staggering. For major operations like amputations or lithotomies, survival was the rare exception, not the rule. The surgeon's greatest triumph was not in closing a wound, but in seeing a patient walk away from his care, a rare and miraculous victory against the unseen tide of death that followed in his wake. To understand the full scope of this brutal art, one must descend into the specifics, to examine the common procedures that formed the core of the medieval surgeon's repertoire. This was not a medicine of gentle cures, but a catalogue of controlled violence, each procedure a desperate gambit played against a backdrop of profound ignorance and unbearable pain. The most ubiquitous of all medical interventions was bloodletting. Rooted deeply in the humoral theory, the belief that an excess of blood, the sanguine humor, was responsible for a vast array of ailments from fevers to madness, the removal of blood was the universal panacea. It was performed by physicians and barber surgeons alike, on the healthy as a preventative measure and on the sick as a cure. The methods were direct and crude. Venesection involved opening a vein, typically in the crook of the arm, with a small, sharp knife called a lancet or a spring-loaded fleam that inflicted a standardized cut. The blood was collected in a bowl, the amount determined by the patient's ailment, age, and the alignment of the stars. It was not uncommon for a patient to be bled to the point of fainting, this loss of consciousness seen as a sign that the corrupt humors had been successfully purged. An alternative was the use of leeches, applied to the skin to draw blood from more delicate areas. A third method, scarification, involved making a series of shallow cuts on the skin and then placing a heated glass cup over them. As the cup cooled, the vacuum it created would draw the blood to the surface. While seemingly less dramatic than major surgery, the cumulative effect of repeated bloodletting was devastating, weakening already sick patients and often hastening their deaths from anemia and shock. For afflictions of the head, migraines, epilepsy, or what was broadly termed madness, a far more terrifying procedure was employed: trepanation. This was the ancient practice of drilling, cutting, or scraping a hole through the skull to the dura mater, the outer membrane of the brain. The rationale was twofold. It was believed that the procedure could relieve pressure within the cranium, but more commonly, it was thought to provide an exit for the evil spirits or malignant vapors that were causing the patient's distress. The surgeon would use a tool called a trepan, which functioned like a carpenter's brace and bit, or a cranial saw to cut a circular piece of bone from the patient's conscious skull. The survival of this procedure, evidenced by skulls showing healed bone growth around the hole, is a testament to the resilience of the human body, but the process itself was an exercise in pure horror. The risk of piercing the brain, causing hemorrhage, or introducing a fatal infection directly into the central nervous system was astronomically high. When a limb was crushed beyond repair or consumed by gangrene, the only option was amputation. This was the signature operation of the surgeon, a dramatic and bloody spectacle of speed and brute force. The patient would be held down, a crude tourniquet of rope, and would tighten high on the limb to slow the bleeding. The surgeon would make a circular incision through the skin and muscle with a long, curved knife, cutting down to the bone in a single, swift motion. The flesh would then be pulled back by an assistant to expose the bone, and the surgeon would take up his saw. The sound of the saw's teeth catching and tearing through the bone was a sound of finality. Once the limb was severed, the ordeal was far from over. The surgeon would immediately seize the glowing cauterizing irons from the brazier and press them against the raw, bleeding stump. The hiss of vaporizing blood, the smell of burning flesh, and the patient's renewed screams filled the air as the surgeon methodically seared every vessel closed. If the patient survived the shock, the pain, and the blood loss, they faced a lifetime as a cripple in a society with little sympathy for the infirm. Perhaps no procedure better illustrates the combination of delicate ambition and brutal reality than couching for cataracts. A common affliction of old age, the clouding of the lens would lead to inevitable blindness. The itinerant surgeon, often a specialist in this procedure, would offer a fleeting miracle. With the patient held immobile, the surgeon would take a sharp needle and insert it into the edge of the cornea, advancing it through the pupil until it reached the opaque lens. Then, with a deft flick of the wrist, he would push the lens downward, dislocating it and allowing it to fall back into the vitreous humor of the eye. For a dazzling, miraculous moment, light would once again flood the patient's retina. They could see. But the triumph was short-lived. The dislocated lens would float within the eye, causing massive inflammation, glaucoma, and unbearable pain. The brief window of restored sight would inevitably give way to a permanent, agonizing blindness, often accompanied by the total loss of the eye itself. These procedures, and others like them, the brutal cutting for bladder stones, the lancing of plague buboes, the stitching of gaping wounds with thick, unsterilized needles, were the grim reality of medieval surgical practice. They were acts of desperation, born of a sincere desire to heal but executed with the blunt instruments of ignorance. Each one was a journey into a landscape of pain, a place where the line between savior and tormentor was terrifyingly thin. The cloistered world of monastic medicine and the grimy urban theater of the barber surgeon were not the only places where the knife was taken to human flesh. There was another, far more chaotic and demanding school for the aspiring surgeon, the battlefield. The constant, endemic warfare of the Middle Ages, from feudal skirmishes to the grand campaigns of the Crusades, was a relentless engine of human injury. It was here, amidst the mud, blood, and chaos of combat, that surgery was stripped of its theoretical pretensions and reduced to its most pragmatic and urgent form. The battlefield was a living laboratory of trauma, presenting the surgeon with a horrifying variety of wounds that were rarely seen in civilian life. There were the clean, slicing cuts of swords and axes, the deep, ragged tears of a mace, and the devastating puncture wounds of lances, arrows, and crossbow bolts. Soldiers suffered from crushed limbs, shattered bones, and catastrophic abdominal injuries. In the aftermath of a battle, the field would be littered with the dead and the dying, and the surgeon's work would begin. He was not a detached clinician, but a triage officer in hell, forced to make immediate, life-or-death decisions. Who was salvageable? Who was beyond hope? Who needed to lose a limb to save a life? The military surgeon was often a man of higher standing than his civilian counterpart. He was attached to the household of a great lord or king, his skills highly valued, his experience vast. He learned his anatomy not from pig dissections but from the open bodies of the wounded men laid before him. He saw firsthand the paths of arteries, the placement of organs, the way muscle and sinew connected to bone. This was a brutal but effective education. War forced a grim practicality upon the surgeon. The elegant, complex theories of the humors had little place when faced with a soldier bleeding to death from a severed femoral artery. The immediate problems were hemorrhage, the removal of foreign objects, and the management of shattered bone. It was in this crucible that small, incremental advances were made, often by individual surgeons who dared to trust the evidence of their own eyes over the received wisdom of the ancient texts. Arrow extraction was a particularly vexing problem. The barbed head of a medieval arrow or crossbow bolt was designed to enter easily but to resist removal, tearing flesh if pulled out directly. Surgeons developed specialized tools and techniques to deal with this challenge. Long, slender forceps, sometimes with spoon-shaped ends, were designed to follow the path of the shaft, grasp the arrowhead, and draw it out. In some cases, the surgeon would have to push the arrowhead all the way through the limb to emerge from the other side, a terrifying but sometimes necessary maneuver. One of the most significant, if controversial, figures to emerge from this tradition was Ambrose Pare, who served in the French army in the 16th century, at the tail end of our period but whose innovations were born directly from the medieval military experience. The standard treatment for gunshot wounds, a new and terrifying form of injury, was to pour boiling oil into them, a practice based on the mistaken belief that gunpowder was poisonous and needed to be neutralized by fire. During one campaign, Pare ran out of oil and was forced to improvise, dressing the wounds with a simple salve of egg yolk, oil of roses, and turpentine. He spent a sleepless night, tormented by the belief that he had condemned his patients to a painful death. To his astonishment, the next morning he found that the soldiers treated with his gentle dressing were resting comfortably, their wounds showing little inflammation, while those who had been subjected to the boiling oil were feverish and in agony. This simple, empirical observation was a direct challenge to centuries of established doctrine. Pare also revolutionized the practice of amputation. He revived the ancient Roman technique of using ligatures, tying off individual arteries and veins with thread, to control bleeding. This was a far more precise and less destructive method than mass cauterization with a hot iron. Though his methods were initially met with fierce resistance from the established medical community, who derided him as an uneducated barber surgeon, their effectiveness on the battlefield was undeniable. War also forced surgeons to confront the problem of infection in a more direct way. While they still lacked a germ theory, some practitioners began to notice that cleaner wounds healed better. Figures like Theodoric of Lucca in the 13th century advocated for a radical idea, washing wounds with wine, the alcohol acting as a mild antiseptic, and encouraging the wound to heal dry, without the formation of laudable pus. He and his contemporary Henri de Mondeville argued against the common practice of packing wounds with dirty materials. They were voices crying in the wilderness, their sensible, observation-based advice largely ignored for centuries in favor of the deeply entrenched humoral theories. The battlefield, therefore, was a double-edged sword. It was a place of immense suffering and death, a testament to humanity's capacity for violence. But it was also the most unforgiving and effective of teachers. It shattered dogma with the harsh reality of trauma. It forced surgeons to innovate, to adapt, to trust their own hands and eyes. The slow, painful crawl of surgical progress owed less to the quiet contemplation of the universities and more to the urgent, bloody necessities of war. As the first millennium gave way to the second, faint glimmers of light began to penetrate the long, intellectual darkness that had enveloped Europe. The world was slowly changing. The growth of cities, the revival of trade, and the intellectual ferment of the High Middle Ages created an environment where the seeds of new knowledge could, at last, begin to take root. This awakening was most keenly felt in the newly established universities, which were emerging as centers of learning, independent of the direct control of the monasteries. In cities like Salerno in Italy, followed by Bologna, Padua, and Montpellier, medicine began to carve out a place for itself as a formal, academic discipline. The University of Salerno, in particular, became a beacon of medical learning, a crossroads where the remnants of Greco-Roman knowledge met with the sophisticated medical traditions of the Arab and Jewish worlds, which had preserved and built upon the classical texts that Europe had largely forgotten. For the first time in centuries, medicine was being taught and debated in a systematic way. Yet, the old schism between the physician and the surgeon remained deeply entrenched. The university-trained physician was a man of books and theory. He studied Aristotle and Galen, debated the finer points of humoral pathology, and learned the complex art of diagnosis through uroscopy and astrology. He was a doctor of medicine, a philosopher of the body. Surgery, however, was still considered a manual craft, a trade beneath the dignity of a scholar. The university curriculum might include lectures on surgery, based on the ancient texts, but the actual practice of cutting was left to the uneducated barbers and craftsmen. This academic snobbery created a bizarre and dangerous disconnect. The men with the most theoretical knowledge had no practical experience, and the men with the most practical experience had no theoretical knowledge. It was a system designed to perpetuate ignorance. However, the intellectual curiosity fostered by the universities could not be contained forever. A new and revolutionary practice began to emerge, tentatively at first, from within the walls of the academy: human dissection. Initially, it was a rare and highly controlled event, more of a theatrical demonstration than a scientific investigation. A professor, the lector, would sit on a high chair, reading aloud from a classical text, usually Galen or Mondino de Luzzi's Anatomia Corporis Humani. Below him, a lowly barber surgeon, the sector, would perform the actual cutting on the cadaver of an executed criminal, while another assistant, the ostensor, pointed to the parts being described. The purpose was not to discover anything new, but to confirm the infallible wisdom of the ancient authorities. If the body on the table contradicted the text, it was assumed that the cadaver was anomalous, not that the text was wrong. Despite these limitations, the act of seeing the inside of a human body, even through the distorting lens of ancient dogma, was transformative. It slowly began to chip away at the centuries of accumulated error. Students and even professors could not help but notice the discrepancies between what the book said and what their own eyes could see. This slow, dawning realization that the sacred texts of Galen might be flawed was one of the most important intellectual revolutions in the history of medicine. It was the birth of empirical observation. Out of this changing environment emerged figures who sought to bridge the gap between the scholar and the craftsman. Guy de Chauliac, a 14th-century French physician who served several popes in Avignon, was one such figure. He was a university-educated man, steeped in the classical tradition, but he also believed in the importance of practical, hands-on surgical skill and anatomical knowledge. His monumental work, Chirurgia Magna, The Great Surgery, completed in 1363, was the most comprehensive and authoritative surgical text of the Middle Ages. It synthesized the knowledge of the Greeks, the Arabs, and his own extensive clinical experience. De Chauliac's work was both a product of its time and a glimpse of the future. He still adhered to the doctrine of laudable pus and the principles of humoral theory, but he also provided detailed, practical instructions for a vast range of procedures, from treating fractures and hernias to cranial surgery and the removal of arrowheads. He insisted that a surgeon must have a thorough knowledge of anatomy, stating, "A surgeon who does not know his anatomy is like a blind man carving a log." The Chirurgia Magna became the definitive surgical textbook for the next 200 years, a testament to its thoroughness and its author's attempt to unite theory and practice. The late medieval period was not a golden age of surgery. It was still a world of unimaginable pain, rampant infection, and profound anatomical ignorance. But the foundations for a new world were being laid. The establishment of universities, the slow acceptance of human dissection, and the work of scholars like de Chauliac represented a fundamental shift in thinking. The body was slowly ceasing to be a purely theological mystery and was beginning to be seen once again as a physical object, one that could be studied, understood, and perhaps, one day, truly healed. The light on the horizon was still faint, and the dawn was yet a long way off, but the deepest, most impenetrable darkness of the long night was beginning to recede. The story of medieval surgery is not a triumphant chronicle of progress. It is a somber accounting of human suffering, a thousand-year testament to the devastating cost of lost knowledge. To look back upon this era is to witness a civilization grappling with the most fundamental of human frailties, the vulnerability of the flesh, while armed with little more than faith, fortitude, and a set of tragically flawed ideas. The legacy of this period is written in the countless unmarked graves of those who died not from their disease or their injury, but from the well-intentioned but lethal interventions of the men who sought to save them. It is a history measured in agony, a narrative whose primary theme is the profound and terrible absence of three key pillars upon which all of modern medicine is built. The first absent pillar was anatomy. For a millennium, surgeons operated in a state of near total blindness, their mental map of the human body a fantastical landscape of misplaced organs and imaginary structures. Every incision was a gamble, every procedure a blind grope into the unknown. They were explorers without a chart, attempting to navigate the most intricate territory in the known universe with a set of directions drawn for a different world entirely. This ignorance was not a simple lack of information, it was a foundational flaw that made true surgical science impossible. Without a precise understanding of the body's architecture, every intervention was doomed to be a crude approximation, an act of controlled demolition rather than of delicate repair. The second absent pillar was antisepsis. The medieval surgeon was an unwitting agent of death, a carrier of the very pestilence he sought to combat. His unwashed hands, his filthy tools, and his blood-stiffened apron were weapons, transmitting invisible contagions from patient to patient, turning survivable injuries into fatal infections. The doctrine of laudable pus stands as one of the most tragic ironies in the history of medicine, a profession that actively cultivated the very process that was killing its patients. The specter of infection haunted every wound, ensuring that even the most skillfully executed operation was merely the prelude to a slow, feverish decline into sepsis. The surgeon could win the battle against the initial trauma, only to lose the war to an enemy he could not see and did not comprehend. The third and most viscerally terrifying absent pillar was anesthesia. The tyranny of pain dictated the absolute limits of the surgical art. It reduced the surgeon's craft to a race against the patient's endurance, valuing speed above all else. It made delicate, time-consuming procedures unthinkable and transformed every operation into a brutal, traumatic assault on a conscious mind. The screams that echoed from the surgical theater were not merely a byproduct of the work, they were a fundamental condition of it. This constant, overwhelming agony inflicted a terrible psychological toll on both the patient and the practitioner, hardening the latter and shattering the former. It created a world in which the prospect of the cure was often more terrifying than the disease itself. These three great absences, of knowledge, of cleanliness, and of mercy, defined the epoch. They were the bars of a cage from which medicine could not escape. And yet, to dismiss the medieval surgeon as a mere butcher or a charlatan is to miss the profound human drama of his position. He was not a sadist. He was a man of his time, working at the absolute limit of his understanding, armed with imperfect tools and confronted with the stark reality of human mortality on a daily basis. He stood in the breach, a flawed and desperate figure, using the only methods he knew to fight back against the relentless tide of death. His courage, to cut into a living, screaming human being, and his compassion, to believe that such a brutal act could lead to healing, are a testament to a strange and terrible kind of hope. The slow fade from this era into the faint light of the Renaissance was not a sudden revolution. It was a painstaking process of rediscovery and correction, played out over centuries. The anatomical revelations of Vesalius, the battlefield innovations of Pear, the eventual, much later, discoveries of Semmelweis, Lister, and Morton, these were the slow, hard-won victories that finally dismantled the cage of medieval ignorance. We now inhabit a world that the medieval patient could not have conceived of in their wildest dreams, a world where surgery can be painless, sterile, and precise, where the interior of the body is not a mystery but a known and visible landscape. We have forgotten the terror. We take for granted the silence of the modern operating room, the blessed oblivion of anesthesia, the quiet confidence of a surgeon who knows the name and function of every vessel and nerve. The story of medieval surgery serves as a somber, necessary reminder of the foundations upon which that modern world is built. It is a foundation of suffering, a bedrock of error, and the accumulated agony of millions. To remember their ordeal is not to judge them, but to honor the depth of the darkness from which we have, by the slimmest of margins, managed to emerge. It is to feel a quiet, profound, and humbling gratitude for the simple absence of pain, and for the light of knowledge that finally, after 1,000 years, found its way in.